I think we can already start the webinar. So I'd like to say hello to all our dear guests. Good day to you in different time zones as we see. I'd like to thank all the participants who are today with us and who attended the previous webinar as well. Special thanks to Dr. Allesio Fasano, who agreed to talk today and share with us very important information about celiac, its past, present, and future. Let me introduce myself, our association, and today's honorary speaker, Dr. Allesio. Hereby, I'd like to say thanks to Dr.Schar company for co-organizing this webinar and supporting celiac people and societies in Georgia and worldwide. Well, I'm Kate Tabatadze, president of the Georgian National Celiac Association. My story is like this, that I have 8-year-old girl who has celiac, and with other 6 moms whose kids also have celiac, we founded the Georgian National Celiac Association just recently in December 2022. Our team is small but committed to do all the efforts to make a change, to improve quality of people with celiac in Georgia. So who are we? I'd like to present our team members. So this is Gwan Sabliadze, she is vice president. Tamar Goroshinadze, she is the director of international relations. Maria Macharashvili, she is the one taking care of our social media activities, which is very, very important. Nino Gabelaya, she is the director of corporate communications. Marika Chkhaberidze is in charge of regional relations, and Tamta Tepnadze, who is our lawyer. So this is us, and this is in brief about us. Today we have already the second international webinar supported by Dr.Schar company. This is a well-known brand because it has a long history, a really long history. Schar brand was founded a century ago in 1922. And for more than 35 years, Dr.Schar company has been dedicated to producing gluten-free products. Increasing expertise and demand in the European market led Schar to open its own research laboratory in 2003. A scientific committee includes international experts, doctors, gastroenterologists, and nutrition experts. So once again, thanks to this company for their efforts in social responsibility that we see in Georgia and in other countries. Now let me introduce our honorary guest, Dr. Allesio Fasano, who is pediatric gastroenterologist. He's the chief of pediatric gastroenterology and nutrition and director of the Mucosal Immunology and Biology Research Center at Massachusetts General Hospital in Boston, Massachusetts. He's also professor of nutrition at the Harvard School of Public Health and professor of medicine at Harvard Medical School. It's interesting to note that in 2000, his group discovered zonulin, a protein associated with gut dysbiosis that regulates intestinal tight junctions. His basic research focuses on bacterial pathogenesis, gut microbiome composition and function in health and disease, the regulation of gut permeability, intestinal mucosal biology and immunology, and SARS-CoV-2. He is director of the Center for Celiac Research and Treatment at Mass General for Children and widely sought after as an expert in celiac disease, intestinal permeability, and autoimmune disorders. Dr. Fasano is the author of Gluten Freedom and co-author with Susie Flaherty of Gut Feelings, the Microbiome and Our Health, which was published in March 2021 by Meat Press. So this is all about us, our association, our honorary doctor, and our supporter company. Let's give floor to Dr. Allesio Fasano and listen to his very, very informative presentation. Floor is yours, Dr. Fasano.
Thank you, Kate. Thank you for the kind invitation, and thank you to the Georgian Society for Celiac Disease, and congratulations for this effort again. I was mentioning a minute ago, this reminds me what happened in United States, a few years ago, and I wish you to make progress in a much faster way. So I was asking to give an overview of what this landscape of celiac disease, where we came from, where we are, and where we're leading to. And to do that, I would like to start with some concept of why some people will develop this disease, where are the mechanisms that are involved. Celiac disease until 10, 15 years ago, we didn't know if it was a food allergy or food sensitivity or intolerance, whatever. Now we know that this is an autoimmune disease. Actually, it's a very unique autoimmune disease. Like every other immune disease has the same features. You need to be genetically predisposed, meaning that you have to have many genes. It's not a single gene kind of disease. That's the reason why you can go generations back and nobody had it, and the next 3 generations may not have it. And then, there are this wealth of gene that comes together in a specific individual, and this brings to the genetic predisposition that will become clinical outcome when the second element that is common to all autoimmune diseases will come in the picture, something in the environment that trigger the autoimmune insult of an organ, in this case, the intestine, that leads to the clinical outcome. Why celiac disease is unique? Because it's the only autoimmune disease for which we know the trigger, that is gluten. We don't know why people come down with diabetes or multiple sclerosis, but it's out of discussion that, it is gluten the culprit. It's gluten the instigator of the autoimmune process. And therefore, celiac disease is the only autoimmune disease for which right now we have a treatment, not a cure, a treatment that is the avoidance lifelong and completely of the gluten-free diet. And you will hear more about the implementation of gluten-free diet from our dietitian, Katerina Mollo, to another webinar that you will have in the future. The other peculiarity of celiac disease is that we have a very strong biomarker of loss of tolerance to gluten in a genetically predisposed individual. There is this antibodies against this specific enzyme that is called tissue transglutaminase, or TTG for short, that, as you see in a moment, has repercussion in terms of diagnosis. So the old paradigm that applied to all autoimmune diseases that now have been recently revisited is that if you are genetically predisposed and you're exposed to an environmental trigger, in this case gluten, this leads to the autoimmune insult. And in our case, again, is damage of the intestine with the villi that gets shorter and so on and so forth. And because the knowledge of the environmental trigger, as I told you, if we avoid gluten and we do this, lifelong, then the immune system that it's belligerent because of this genetic predisposition has no enemy to fight and will shut down the ammunition, and that leads to the repair of the autoimmune insult of the intestine, and with that, resolution of the symptoms, and therefore, back to a state of health. That's the paradigm that we've been living with. How do we learn about these two elements of celiac disease? Well, in terms of the genetics, let's take a look at these two elements. Well, there are several genes involved. Up to now, a return of my voice in my. I don't know what is this. Do you hear that as well? No, I'm sorry. It's my fault. So anyhow, there are several genes involved. Most we don't know. But the one that we know, that is the HLA genes, DQ2 and DQ8, they must be there. Without that, you cannot develop celiac disease. So there are many other genes, of course, probably thousands, but they account for the vast majority of the inheritance of celiac disease. But the HLA is a must. Without that, you cannot develop celiac disease. So it's absolutely necessary, but not sufficient genetically. The second element, i.e. the environmental trigger, was unknown until a few decades ago. This gentleman is a Dutch pediatrician, made the observation during World War II. That's when we learned that gluten is the instigator of autoimmune and celiac disease. How did he discover this? Well, celiac disease at that time was a disease that was very serious, was a pediatric disease, and roughly carried a strong weight in terms of mortality. 35% of these kids will die because of this malabsorption and malnutrition. What Dickey observed during the war is that the mortality went to zero, to then return to 35%, after the war. And he started reasoning what we miss in the Netherlands during the war that could be responsible for that. And he narrowed down to wheat flour being the culprits. And therefore, he did an experiment, so to speak, that now would be totally unfeasible. He took 6 of these kids with celiac disease, put them on a gluten-free diet, showed that, the gluten-free diet will eventually resolve their symptoms of malabsorption. And then he re-exposed them to gluten to show that re-exposure will eventually reignite the insult to the intestine and therefore the symptoms. And that's how we made the connection. This was 1949. So before that, we didn't know that gluten was the culprit. And of course, when we talk about gluten, now we know there's not only wheat, but also rye and barley seems to be a part of the tribes of the grains that are responsible to induce, this autoimmune insult in genetically predisposed individuals. What happens when these two elements, genes and environment, come together? What is the clinical presentation? This has been a challenge for many, many years. And the reason why there is a lot of confusion, particularly when healthcare professionals, like probably in Georgia, and mostly among adult gastroenterologists, are not aware how difficult and complex is the clinical presentation of celiac disease. It's been considered sort of iceberg, a sort of iceberg in which only few cases are visible. These are the people that they have the genetic predisposition, they have the autoimmune insult of the mucosa, that they have the autoantibodies present, and all this translate in symptoms. So because they are sick, they go to the doctor to eventually get an advice on what could be wrong with them. But these are the exception. The vast majority of the quote-unquote celiac iceberg is below the line of water, meaning that the vast majority of people, they have the genetic predisposition, they have the positive serology, they have the damage of the intestine, but they are not clinically apparent yet, either because they don't have symptoms at all, or because they have symptoms that are so vague and tolerable that they don't go to the doctor. A stomach ache here and there, a little bit of nausea, maybe a couple of days of diarrhea on and off. So these are symptoms that will not bring you to the alarm level that you need to go to the doctor. And then, there is another part of this iceberg that we call latent celiac disease, in which, the genetic predisposition and the positive serology that since something's going wrong is there, but the autoimmune insult doesn't materialize yet. When all this perfect storm come together, you have the clinical presentation, and these are the kind of kids that Dickey was looking at that time. So these are the classical picture of the malabsorption syndrome of kids with recurrent diarrhea, big belly, lack of appetite, they didn't grow, stomach ache, and so on and so forth. And these are the ones that eventually, if not treated, will go to the celiac crisis, so-called, that is the one that translates actually in death. Of course, thankfully, we don't see these kind of cases anymore. This is not the way the disease presents itself. But if you look very careful at these 5 kids in this picture in the mid-30s from London, you will, recognize features that we still see this in developing countries in malnourished kids. So in other words, kids from, North Africa and so on and so forth. Well, those kids, they look like this because they don't have food to eat. These kids, on the other hand, had all the foods of this world, but this food cannot be digested and absorbed. So practically, they could not make use of the food that they were ingesting. And the clinical outcome was the same. Again, we don't see this anymore. This is not the way the disease presents itself anymore. Now, the what we call classic gastrointestinal manifestation are not this one. What we see now are situations that are much more, protiform in terms of, clinical presentation. And the bottom line is, even if the damage occurs in the GI tract, any tissue or district of our body can be affected. So you can have only the skin to be affected. You develop dermatitis piriformis. You can have, defect of the enamel of the teeth. The bones can be affected. You can develop osteopenia, osteoporosis. Particularly in kids, you can have short stature and so on and so forth. We're going to revisit some of these symptoms because now they're becoming more and more frequent. But all this to say that, again, the challenge for the physician and the healthcare professional is indeed to link symptoms that are not specific for celiac disease to the possibility of celiac disease. And if you are not aware the way the disease presents itself clinically, you can clearly miss it. And again, in the past, the gap between the onset of the symptoms and somebody will make the diagnosis was measured in 12, 13 years. Now, thankfully, this gap is much shorter, but still, in some reality, even in reality like in the US and Europe, where the awareness is very high, you still have cases that will take several months to be diagnosed. So these are people that shop around, try to figure out what's wrong with them. Let me give you some few examples of the way that, the disease can present itself. I have the automatic, recording in the background, so I apologize if I have to go back and forth with these slides. Anyhow, one strange but interesting and very disturbing way in which the disease presents itself is this, ulcers in the mouth, what we call aftes. So it's an inflammation of the mucosa in the mouth, or technically called stomatitis. It's extremely painful. People cannot drink or eat regularly because everything burns in their mouth. And sometimes this is the only clinical presentation of the disease. And of course, if you're not aware, you go to the dentist, you go to the oral hygiene, doctor, and he or she may not be aware of celiac disease, and you will not be screened. So that's a weird way that disease presents itself. This is another very weird way in which the disease presents itself. That is the skin manifestation typical celiac disease that we call dermatitis piriformis, or DH for short. It is a very disturbing skin rash because it's extremely itchy, very, very uncomfortable. It's severe itchiness. In general, it's symmetric, so in both parts of the body, typically the elbows and knees, buttocks. The vast majority of these people have no GI symptoms. Again, a dermatologist is not aware that this can be related to celiac disease. This individual will be now screened and will be treated for something that will not go away unless diagnosed as celiac and placed on a gluten-free diet. The diagnosis is made by doing a skin biopsy that shows the typical features associated to gluten insult that leads to this skin manifestation. So the most frequent way that the disease presents itself nowadays, both in kids and adults, are not GI symptoms, rather anemia. And the anemia is mostly related to low iron levels. So in other words, there is a malabsorption iron that is absorbed only in the very first part of the intestine. So if that part is inflamed, you do not have a backup. And because of that, you develop, this anemia that over time becomes severe enough that these people will eventually have also fatigue, because when you're anemic, of course, you develop fatigue. Again, right now is by far the most frequent way in which the disease presents itself. Osteoporosis is another way that the disease presents itself, contrary to what is the common sense of, this kind of pathology that in general affects people at a certain age or postmenopausal women. Unfortunately, with people that are affected by celiac disease can really be present at any age. And we see this even in kids. And now it's been established that osteoporosis are relatively frequent in people with celiac disease that have been untreated for a long time. As a matter of fact, celiac disease is the most frequent cause of osteopenia or osteoporosis in men at all ages and in women in premenopausal age. So the other thing that is important is, particularly in pediatric, is that if you do not have enough calories because you have malabsorption, of course, the priority of the calories and energy that you are able to get on a daily basis goes to vital functions like, making sure that the heart pumps, that the brain is oxygenated, and so on and so forth. So the energy that you need in pediatrics to be growing would not be a priority, or for reproduction. And therefore, the periods would not be a priority. So kids that they suffer celiac disease untreated, unfortunately, may present exclusively with short stature. And the major problem here is that if we do not make the diagnosis on time meaning before the onset of puberty, chance existed that we lose the capability of catch-up growth, meaning that these kids will stay short for the rest of their lives because we missed the diagnosis. And of course, this is a travesty that needs to be avoided. Now, another interesting and very peculiar way in which celiac disease presents itself clinically is a manifestation that has to be with the nervous system. There are a lot of the manifestations that are rather common in people with celiac disease. They can go from very minor, like, irritability, mood swings, short memory loss, but to much more impactful and serious conditions like anxiety, depression, seizures, ataxia, attention deficit disorder, schizophrenia, and so on and so forth. And in this situation, I want to present a very challenging case just to emphasize how complicated sometimes is to make the right diagnosis if the symptoms would not guide you in the right direction. And this is a case of a young lady, 39 years old, that had a 6 months history of abdominal pain and reflux kind of symptoms, heartburn. Well, these are very frequent symptoms, nothing really specific and peculiar about this, but the next step of her clinical journey became, kind of complicated. When we have the suspicions of gastroesophageal reflux, we put these patients on antacids, in this case, PPI. She had symptoms that unfortunately did not resolve, despite that empirically she was treated that way. But what really started to be a worrisome evolution of the story is that she, 1 month after the onset of these GI symptoms, she developed headache, dizziness, numbness of the finger, loss of sensation in parts of her body, gradual reduction of muscle strength, and in a matter of a couple months, she was forced in a wheelchair. By the way, she was a runner, a marathon runner, so she was an active, individual. So, of course, these are very, very concerning symptoms that brought her to be worked out for what seems to be the most logical next step. So the neurological causes of a patient like this seem to suggest conditions like multiple sclerosis or other neurological symptoms, and therefore her doctor prescribed an MRI, evoked potentials, and good for her, everything was negative. And so the multiple sclerosis diagnosis was, ruled out. However, other diagnoses were engaged, like Lyme disease, an infection by a virus that can give symptoms like this when attacked nerves, like Epstein-Barr virus, pernicious anemia, lupus. Anyhow, even those conditions were all ruled out. And, the question remained that now we have an impaired, very much impaired individual on a wheelchair with no apparent cause of her symptoms. In the meantime, because the gastrointestinal symptoms of reflux persisted, she underwent to an endoscopy, mainly to, look at this reflux. And interestingly enough, and surprisingly enough, the endoscopy showed typical sign of celiac enteropathy, so blunted villi. And because of that, afterwards, she did a blood test and she tested positive for celiac disease. So she was accidentally diagnosed with celiac disease because she had to go on to undergo the gold standard diagnostic test, i.e. an endoscopy, for total different reason for reflux. After that, she, of course, was placed on a gluten-free diet. And within 3 weeks, the GI symptoms resolved. So reflux resolved. Within 2 months, the neurological symptoms also improved. 6 months later of the implementation of the diet, she was able to walk with assistance of a cane. And after a year, she regained completely her walking function. So what she experienced was what we call a peripheral neuropathy, so an attack of the peripheral nerves that we know can be part of the celiac disease outcome. What is the lesson learned from this case is that, again, nobody thought that this could be celiac disease, and she was diagnosed by chance. And if she did not have the reflux symptoms, and therefore if she did not undergo to an endoscopy, chance exists that she was still in a wheelchair, not knowing what was going on. And of course, the attack of the nerves, if it continues for many, many months, may be irreversible. So if the diagnosis was made too late, most likely she was not able to regain completely her function. So this brings me to the point how we can suspect celiac disease and what kind of diagnostic algorithm I should use to really rule out the possibility that that kind of patients with that kind of peculiar sign or symptoms is affected by celiac disease. That's another peculiarity of celiac disease among all the chronic inflammatory disease in general, but particularly about celiac disease, that we have very strong diagnostic tools. These screening tests, these blood tests, particularly the anti-TTG antibodies, are very, very robust in identify people with celiac disease because they have a sensitivity, meaning that they can really detect, a large number of celiac, and a specificity that they test positive only in celiac and not any other conditions. That is almost perfect. It's got close to 100%. It's not quite there yet, but it's pretty strong. We have also other testing beside the gold standard, that is the TTG IgA antibodies. like anti-endomysium antibodies that we do in specific cases that we can discuss in a moment. And then we have the IgG isoform of the TTG antibodies, and also of another test that we call deamidated gliadin antibodies that we do only when we suspect IgA deficiency. In other words, an individual that don't make IgA antibodies, of course, if you do TTG IgA, would test falsely negative, and therefore would be missed the diagnosis. So if the first test that we recommend is TTG IgA plus total IgA. If there is a IgA deficiency, then we reflex to the IgG anti-TTG antibodies or IgG deamidated gliadin antibodies. And we will talk about the HLA in a moment, when and what is the rationale to test for the genetics of the HLA. Now, particularly in pediatrics, when we have people positive with this test, the next step is to do an endoscopy, like the lady that I present as a case. Why we need to do an endoscopy? Well, because even if it's extremely robust, this test is not infallible. So sometimes we have people that test positive and then we do an endoscopy, they don't have celiac disease, it was a false positive. And the diagnosis implies change in the lifestyle forever, for the lifespan of the individual. So we need really to have solid evidence of the correct diagnosis. And that's the reason why in a typical situation, we follow this screening test with a confirmatory test that is the endoscopy that show the autoimmune insult. However, over the years, there have been a lot of discussion of avoiding an invasive procedure, particularly in kids. In other words, try to avoid that these kids will undergo to general anesthesia to do an endoscopy to take these biopsies. And we were not capable to do that until the recent past, because again, that possibility of false positivity with relying simply on anti-TTG antibodies. And a few years ago, a pediatric society that had convened a panel expert of celiac disease come up with this algorithm that seems to be very complex, but will bring this down to the simple basic rule in which if you satisfy some criteria, you can avoid the endoscopy. And by the way, this is a protocol that applies only to kids. In adults, the general agreement is that you still need an endoscopy to make the diagnosis. No exception made. In pediatrics, if the kids have symptoms, so cannot be asymptomatic, 12 symptoms, and will be tested for the TTG antibodies, and these TTG antibodies are 10 times more than normal. Let's say the cutoff is 4 and the kids test 50, so 10 times more. If these kids need to reflex with the second antibodies, there is the anti-endomysium antibodies, and with the genetics. So look for the gene compatibility with the HLA, DQ2, DQ8. If also this would be positive, then we're here. Then the diagnosis of celiac disease can be made without an endoscopy. All the other scenarios that are depicted here will bring to the biopsy. So the only way to avoid the biopsy in the kids with celiac disease suspicious is that the symptoms need to be there, the TTG needs to be extremely elevated, the anti-endomysium needs to be positive, and the HLA genetic compatibility has to be there. Those are the criteria that needs to be satisfied to avoid the endoscopy. Now, once you diagnose, what's next? What we do with these patients, we follow over time, because after that diagnose, they need to sit down with a capable, knowledgeable dietitian like Katerina that we'll hear again in the next one of the next webinars that you will organize, and will teach how to implement the gluten-free diet. Of course, this is a diet that will require some time to be learned, a mistake will be made, and so on and so forth. And then the expectation is that the symptoms will go away, that the autoantibodies will go away, and eventually that is going to be full repair of the autoimmune insult in the intestine. So the villi will come back up. Now, while the performance of the TTG antibodies is extremely robust, as I mentioned, as a diagnostic tool, is not that good for monitoring. We still use it, but we have seen, many cases in which the TTG stays elevated. However, the symptoms are gone and the intestinal repair is completed. And we've seen the opposite. We see patients in which we check for the TTG, they're now back to normal, but they still have symptoms, and we repeat an endoscopy, the damage is still there. So all this to say, why we have very robust biomarkers for diagnosis, we do not have very robust, biomarkers for, monitoring to make sure that everything is repaired. Both in adult and symptoms, both in adults and kids, the repair of the damage doesn't really match with symptom and serology. So even if people they have asymptomatic and normal serology, they can still have damage there. So that's not a challenge. So now we know that 30% of patients may be asymptomatic at diagnosis, and study also show that symptoms do not correlate with the mucosal damage. So you can have very mild symptoms that you have a total destroyed intestine, or you can have extremely severe symptoms and the damage is mild, it's not extremely severe. And again, as I told you, negative tests poorly correlate with the outcome of the gluten-free diet. For mucosal recovery, so in other words, to be sure that the damage is completely gone, the only objective marker is the endoscopy until we find something else. Now, let's move to the HLA. What is the meaning of the HLA tests? As I told you, this is a must. If we don't have either or both of this DQ2, DQ8, somebody cannot develop celiac disease, because 95% of people with celiac disease have the DQ2. The remaining have DQ8 either alone or in combination of celiac disease. However, these genes are common also in the general population, not as high, look, everybody, but 30-40% of the general population may have DQ2 and or DQ8. So why we test for this? Not for the diagnosis, because if I test positive, I cannot tell if I'm in the group of the 99% people with celiac disease or the 30% of the general population. We test for HLA to rule out. So that, in other words, when you are diagnostic, dilemma, if I do HLA testing and the test is negative, I can tell with great level of confidence, not certainty because there's no such a thing in medicine, but great level of confidence this individual would not have celiac disease because the genetic test is not compatible. Why we do this testing? For asymptomatic relatives, we know that, if somebody is diagnosed with celiac disease, the rest of the family needs to be checked because, the increased risk. And the question is, how frequently do I need to check them? And the answer is, well, it depends if genetically compatible. If beside the TTG test, I also do the HLA and the HLA is not compatible, that individual doesn't need to be tested anymore. But if it's genetically compatible, then you need to keep an eye on it and you need to test, recurrently and have a low threshold for testing. Genetic diseases that we know to have high comorbidity with celiac disease, that's where the genetic test could be the value, like Down syndrome, Turner, Williams, so on and so forth. Other autoimmune diseases like diabetes, definitely not a reason to do that. And diagnostic dilemmas. So many times people come to the clinic, they already start a gluten-free diet, and the only way to make sure if they have celiac disease or not is to do what we call a gluten challenge. And many of these people, they don't want to do that because they will get sick if they have to expose themselves to gluten, but they have not been tested formally before embracing the diet. Those are the individuals in which we consider the possibility to do the HLA, DQ2, DQ8. And if the DQ2, DQ8 are negative, we can tell them with great level of confidence that the reason why they react to gluten is not celiac disease, but must be another gluten-related disorders like wheat allergy or gluten sensitivity. I want to finish to give a little bit of the future of celiac disease, because so far we've talked about the past and the present. The future of celiac disease is that now, contrary to what we believed before, the gluten-free diet is not efficient to control the symptoms in everybody. The vast majority of the people with celiac disease will respond to the gluten-free diet and will live a happy life. But there are a group of individuals that, despite the best effort possible, so they don't cheat, they do everything right, and so on and so forth, they are not capable to control their symptoms. I want to just make a disclaimer immediately the fact that, unfortunately, I don't know what is the situation in Georgia, but we start to see here stuff popping up, like this stuff in the pharmacies that claim that, these enzymes or these pills can help digest gluten, and therefore, when you're exposed, either inadvertently or because you want to have a beer, being celiac, you can take this and you will be protected. This is absolutely no. This is all scam stuff, because right now there are no treatments that have been validated and approved by anybody that control, the use of gluten, treatments other than, celiac treatment other than gluten-free diet. There have been no approved drug on the market yet. So these are scams. These are very dangerous for people with celiac disease to consider. And matter of fact, to validate, this, we have to come up with, some very clear strategies. Why we embark in this? Because, as I told you, it's not completely efficacious. There are 30% of patients that persist with signs and symptoms. These are the non-responsive celiac. Very few of them are refractory celiac disease. It's a very different category of individuals that definitely would not respond to the gluten-free diet. And more than 40% of adults on a gluten-free diet have persistent villus atrophy, with or without symptoms, even after 5 years. And the same applies, thankfully, on a much lower percentage in kids. And that leads to the fact that we need to eventually consider alternative treatments or complementary treatment, I should say, to the gluten-free diet. And I will just briefly mention to prevention, because the future really will be prevention in people who are genetically predisposed. Why we can really develop these new strategies? Because now we have a major understanding of what it takes to eventually develop celiac disease. This is a cartoon that I'm not going to go through because it's way too technical, that explain what happened after that I eat something with gluten in there to my gut mucosa that leads to its destruction. So each of the steps that you see in these numbers 1, 2, and to all the way to 6 here are possible targets for therapeutic intervention. And until, a few years ago, there was nothing. Now this is not really an updated, slides, but still will give you a sense there are more than 260 registered clinical trials, mostly more than 100 focused on pharmacological intervention complementary to the gluten-free diet. This clinical trial is happening worldwide, everywhere. And you see the darker, the more clinical trials are happening, are in different phases. Of course, the clinical trials, they go in phases. The phase 1 is very early, just to make sure that whatever drug is considered safe. And then from phase 1 to phase 3, you go different level of sophistication for efficacy. So in other words, to make sure that does what it's supposed to, i.e. protect the individual against exposure to gluten that will lead to a damage. Again, this is a very complex slide, but just to give you a very short synopsis of all the categories of this 100 plus drugs that are in clinical trials. They go from anti-inflammatory drugs like steroids to enzymes that break down gluten more efficiently, that stabilize the gut barrier, that modulate the immune system, that are inhibitors of specific enzymes, or the genetics that can create the problems, the probiotics, and so on and so forth. What is my take-home message here? That unfortunately the gluten-free diet is superbly efficacious in the vast majority of people, but not all. And for that percentage that would not be able to handle celiac disease with just the gluten-free diet, we need this other additional push with these other medications. They are in the pipeline for development. large number of patients want treatment options of gluten-free diet. And not only for those that do not respond to gluten-free diet, but also for the ones that respond and they're in not safe environment. So I know that when I'm home, I can implement the diet correctly. But what about when I travel, when I go to friends, when I go on vacation? Having a safety net that will protect me, even if I stick with the gluten-free diet, will give me the peace of mind that if somebody will make a mistake, I will be safe. Last couple of slides on prevention. So as I told you, the old paradigm of autoimmune disease, including celiac disease, that two elements were necessary, sufficient. And now we see, for example, epidemiologically speaking, that celiac disease, like any other immune disease, increase over time. In a period of time that's too short to blame these two elements to be responsible for this increase. In only 30 years, there have not been genetic mutation in human beings to increase the risk of celiac disease or genetic mutations in the grains. And yet we see that celiac disease doubled every 15 years. So yes, these two elements are necessary, but not sufficient. There are other elements at play. The most important is the ecosystem in our gut, what we call the microbiome, that seems to be extremely influential to decide how we play our genetic cards, switching from genetic predisposition to clinical outcome. And therefore, there is now the possibility by studying, the evolution of the microbiome from birth until the onset of the disease, what kind of shift that can happen in a preclinical stage that brings me to the wrong direction and therefore to develop celiac disease. And these kind of studies have been embraced on our center for the past 10 years with this project that is called the Celiac Disease Genome, Environment, Microbiome, and Metabolomic Studies, so CDGEM for short, that follow kids from birth that are at risk for celiac disease because somebody else in the family has it. And we have done this, studies that led to an unbelievable funding so that we identified specific shift in the microbiome that precedes months of the onset of disease, and therefore gives us with great level of prediction through also some artificial intelligence analysis to tell us who, having these changes, will develop the disease down the road. If indeed this will be confirmed on large numbers, this shift in microbiome, so this change in microbes, can potentially serve not only for a biomarker to tell me this kid in a month or 6 months, in a year, will develop celiac disease, but give me also a target of treatment so that I can intercept the disease and make sure that who is genetically predisposed remains as such and will not develop the disease. I want to finish to thank you guys to give me the chance to chat with you and on behalf of the entire celiac, the Center for Celiac Disease and Treatment at MGH. Of course, I have to thank, the folks that made these projects possible, particularly, entity that gave us the money to do this research, the group that has been working on these projects for many, many years, but most important, particularly for the CDGEM, the kids that made all this possible and their families, because without them, we would not have this kind of research. So that's as much as I need to share with you folks. And I hope that, we can have time for questions if there are any.
Thank you, Dr. Fasano, so much. I have also texted in message box that if doctors or other participants have questions, they can leave their comment there or even ask directly. And now we have the first question that I see here. There are two questions from Sandro. So how common is celiac disease in people with mental health disorders, for example, schizophrenia, bipolar, major depression? And there
have been a few systematic studies in people with mental disorders, and let me talk specifically of schizophrenia because it's a study in which we've been involved when I was still at University of Maryland. The number is not negligible. And, between 10 and 15% of people with schizophrenia they have an immune response to gluten. Now, of course, the vast majority of schizophrenic individuals do not, but 10-15% in the big scheme of a condition which we have nothing else, and these people are lost to the society, to themselves, it's a huge number. To the point in which, we start recommended to screen all schizophrenic people for serious disease. That will be a logical way to go. But, the answer to this question can be only, addressed when we have more systematic studies, with other conditions. If I can revolve the question, I said, how frequently people with serious disease, they experience anxiety, depression, and so on and so forth, it's a pretty large number. The argument can be made that you can be depressed because you've been diagnosed with a chronic condition that you're not going to, get rid of for the rest of your life, and that will make people depressed. But there seems to be a neuroinflammatory mechanisms that is involved there, because once these people, they go on a gluten-free diet, some of them, not all of them, but a good, proportion of them, their depression improves or even resolves, and they don't need antidepressant medication anymore.
Thank you. There was also a second question about these people. How about the routine of testing for celiac people with these problems?
Yeah. Honestly, it's a matter of cost-benefit ratio. Because the cost of the screening is relatively low, we typically use a low threshold. So in other words, when you have somebody with schizophrenia or depression, for example, and you've done everything under the sun to try to find the cause, and you can find nothing, it doesn't take that much to invest, a few, for us it's $40. I don't know what is much in Georgia to do a test, because the return on investment is huge. So we typically use low threshold.
Thank you. And we have another question from Dr. Bizina Kulumbego. He says, thank you, and asks, what complications could untreated celiac disease cause?
That's a very good question. This is typically what patients ask us. So what's going to happen to me if I decide to not go on a gluten-free diet, because I may be asymptomatic, because I was screened as a family member, or I have bearable symptoms like stomachache here and there? The answer is, I don't know. The most frightening, complications is that you will have an autoimmune attack to other organs, tissue in your body. The most frequent now is Hashimoto thyroiditis, type 1 diabetes. Hashimoto now is contributing almost 20%, type 1 diabetes 7%. Of course, osteoporosis is a big deal. We discussed about short stature in kids that definitely we want to avoid, and so on and so forth. Worst case scenario, you can go all the way to intestinal lymphoma. It's rare, but that's another possible evolution. So these are serious consequences. The problem is that if you have somebody with diabetes and you don't treat, this individual will die relatively quickly, because metabolically cannot support being without insulin. People with serious disease would die slowly, both the quality of life and then physically die, because the mortality rates untreated serious disease is almost 3 times more than in general population.
Thank you for your answer. And we have another question from Nino Gabelaya. Why does it happen that child is on gluten-free diet, but she still has ankle pain periodically? Her stomatitis after eating feels tired.
Yeah. Once again, the challenge of celiac is that these symptoms are not peculiar of celiac disease, but can be due to many other reasons. So you can be tired for many other reasons other than celiac disease. You can have ankle pain for other diseases. So again, compared to other autoimmune diseases in which the symptoms are so specific that you have cause effect, that's not the case for celiac disease. The rule of the game is the following. If a kid has symptoms that are compatible with celiac disease, you put him or her on a gluten-free diet, once diagnosed, you expect that the symptoms will go away. If they will not go away, you have two possible scenarios. They are due to something else, or the celiac disease is still ongoing. For what we discussed in terms of monitoring, this second scenario can be ruled out only if we repeat an endoscopy to show that the symptoms are still there because the damage is still there, because the TTG test can be negative, but the damage is still there. So a repeat endoscopy would be, in this case, something that we definitely entertain as a possibility.
Thank you so much. And I have one question about what you first started your presentation with. We do not have a cure for celiac for now, but there are some treatments. Can we expect cure anytime in future?
Expect what now?
Cure for celiac.
I'm not sure that I understand. Keyword?
Cure. No, we have no treatment, but it's not cured.
Well, that's our hope. Definitely, we're aimed in that kind of direction. That we definitely, my sense is not a question if. My feeling is when. And this depends on many variables, how quickly we got there. Some of that we don't control. An economic crisis that it would not give us the opportunity to have resources to move the science forward would be a war, a earthquake, you name it. So these are elements that we don't control, but we're going to get there.
Thanks for such a positive answer to this question. And there is also one answer from Khatia Khodelidze. She asks, can I recommend anything specific despite GFD to an athlete who wants to gain weight?
Yeah, I mean, of course, once you go gluten-free, you expect to regain some weight that you lost, or you got more weight gain. If there was an issue in terms of malabsorption, anything that increase appetite, like periactin or anything like this, would be something to consider to help you regaining weight to an individual, particularly in kids, but even in adults. So, or use hypercaloric stuff like milkshakes that boost, or anything that is hypercaloric. So small volume but very dense in calories, butter, that kind of stuff. But again, Catherine Mollo, probably our dietitian, can expand even more when she would talk about management of celiac disease in terms of diet and nutrition.
Thank you so much, Dr. Fasano. We will have a very interesting webinar with Caterina Mollo also, and we will announce it in the coming days. I know that you are limited in time, and if we have more questions, we can receive it on our email, the GNCA email for our association. And if you don't mind, we could contact you later if there are some specific questions.
We'll be delighted to answer. And again, thank you for having me. Really much appreciated.
Thank you so much personally
to
everybody. You and your. Thank you.
Thank you so much.
Thank you again for having me. Bye. Bye, everybody.
Bye.
Thank you. Bye-bye.
Bye.